Okay, all yours, Nikki.
Yeah, thank you. I can't see as many faces now or screens now, but lovely to see so many people on the session today. So thank you for joining us. So I'm Nikki Cotterill. I'm a professor of nursing and continence care at UE in Bristol, and I'm also the director of the BABCON HIT, which is the Bladder and Bowel Confidence Health Integration Team. And this enables us to take a system-wide view on improving continence, because what we often find is that continence or incontinence sits on the edges of lots of clinical specialities or conditions and isn't the primary focus often, but also affects lots of different population groups and isn't necessarily a particular focus of a particular group. So what we found was that continence or incontinence often slips between the cracks. And we wanted to have an identity and a focus that enabled us to work across all of our partner organisations in the local area to look at incontinence in the whole and how we can improve the landscape for people who experience incontinence from all different perspectives. So sort of out and about in daily life, clinical research, care and how it's provided, and sort of really have a really good robust network. So everything I do is continence related. The main thrust of my work is continence research. I've worked in this field for about 20 years, but sort of the different hats I wear essentially enable us to work in different ways to improve the landscape. So today I just wanted to hopefully provide a bit of an overview as to how incontinence can be associated with stroke and other reasons, but also then think about what can be done and what we don't need to necessarily accept, and hope that provides some insight and some resources and some sort of signposting to ways forward. I'm very happy to take any questions at the end and also be approached going forward if things emerge with particular relevance to continence and you think, oh, do you know that the BABCON HIT or Nikki might be able to help, then yeah, we're always keen to hear and hear ideas about what's not working so well as well, in terms of we might be able to do some work around improving that. So without further ado, hopefully I can make the slides move on. There we go. Before I get into anything specific about incontinence in the general population and then incontinence in stroke, I just wanted to really talk about demystifying incontinence a bit. So often what we think about when we think of incontinence is shaped by either our experiences or what we've seen or what we've heard over the years, and often it's sort of typified as this kind of urgent moment, can be like a catastrophic accident, as in, complete loss of all of your bladder. And it might just be for certain people in the population that it's viewed as. But what I really wanted to sort of highlight is that incontinence is actually the term we use for any leakage. So any leakage from the bladder or the bowel. We tend to focus, or the focus tends to be more on the bladder, but we absolutely include the bowel. So, and also what isn't so often recognised is we even think about things like the accidental loss of wind, because we know that if you accidentally let out a bit of wind and you can't control it, that the smell and the sound can be audible. So it isn't only about thinking about kind of the catastrophic end of the scale of what incontinence can be, but recognising that any leakage that you're unable to control from bladder or your bowel is considered incontinence and is worthy of pursuit of treatment, or thinking about, can I get some help and advice around this? And also to recognise that this can affect people from childhood right through to older adulthood. There tend to be some sort of stereotypes around it being for being more relevant for people in their older adult years, or that it's just what it happens when you've had a baby, is quite often sort of thrown around. But actually it's about demystifying, for me, that anybody who experiences any bladder or bowel leakage shouldn't normalise that, and we don't have to accept it, and that there is advice and self-help, and as well as more formal services out there that can help to improve those symptoms, or if they can't be cured, for example, learning how to live well with those symptoms, manage those symptoms, and also understand what's going on and perhaps understand things that might trigger it or make it worse, so that it's not just happening to you and you're a kind of passenger to it, but that there might be able to be something that can improve the situation. So that's the kind of, if nothing else, you take away from this talk, then just sort of being able to highlight that it relates to anything. There isn't a frequency, you don't have to have accidents that happen on a daily basis to be considered incontinence, or it doesn't have to be of a certain severity. It's just any leakage is really worthy of pursuit of some information, advice, treatment, whatever that might be. And just to put it into context, I know I'm here to talk about incontinence after stroke, but that essentially many people in the country do experience incontinence. So in the general population, we know it's about 1 in 3 who experience bladder control problems, and this varies at different time points and for different reasons. And it's not wrong that there is an increase with age. That wasn't an incorrect fact. It's just not an inevitability, and it's not anything that we just have to accept because it's happened with older age, for example. And we also know that about 1 in 7 experience bowel control problems, and we know constipation is a big issue as well. And whilst constipation seems completely the opposite of incontinence, not being able to go surely can't lead to leakage, but the fact that somebody is unable to go can lead to overflow leakage. So quite often sorting out the constipation can sort out the incontinence. So it's just to put it into context that this is a wider issue. It certainly is associated with stroke, and in the period after stroke, an increased occurrence of incontinence, but that it does happen to more people than we think anyway within the population, and for many and varied reasons. And I'm going to go into those now as well. But it's also to recognise that these reasons may be sort of why somebody's experiencing incontinence, as well as, or may have already been prior to stroke, for example. So do need to be taken in considering that individual as a whole, rather than necessarily just the impact of the stroke. So children and young people and sort of early toilet training and those kind of enduring problems that continue into adulthood definitely need addressing or seeking support sooner rather than later. There's a common assumption that children will just grow out of problems like bedwetting, and some do, but it's about kind of actually intervening and making sure they get the support they need to enable that progression and to improve their symptoms as soon as possible. Pregnant women, there's a lot of additional weight to carry around that puts pressure on the pelvic floor, and the pelvic floor really is the crucial component to retaining continence. It's about that hammock that sits below all of the organs in the abdomen for both men and women, and so the muscles that hold all those organs in are key, but also the nerves that supply those, all of that area is key as well, and how all that works together and coordinates. So women who are carrying babies have an increased pressure on the nerves and on the pelvic floor. And then, of course, once they've had children, there can be difficulties during childbirth that can cause problems with incontinence, such as tears, that need to be really aware of. Menopausal women, often some of these symptoms can have been at a low level for a while, and then sort of really become apparent during the menopause because of changes in hormone levels. Men following prostatectomy, we're much better at identifying prostate cancers now, and we're really proactive about treating them, but some of the consequences can be altered levels of continence, and therefore, really identifying problems here is key. As I mentioned, chronic constipation. And then conditions such as dementia, diabetes, heart failure, conditions that aren't necessarily thought to be in relation to incontinence, but can have impact on other factors that can influence incontinence, such as the nerve supply, as I say, to that area. Older people, as I said, the degeneration that can occur can lead to emerging incontinence, but not that it has to be accepted as an inevitability, just that it might occur and that we can do things around that. People with learning disabilities, understanding the cues to use the toilet and the messages, and identifying the places and sort of whether they've been properly encouraged to toilet train in the early years, can all have an influence, and so they can be an increased risk of continence difficulties, mental health problems and musculoskeletal problems, things like actually mobility and reaching the toilet, and also other reasons that might be triggers for incontinence, sort of coping strategies with mental health problems such as drug and alcohol use, that kind of thing can incur, but also incontinence can be a cause of some mental health problems as well. And then we come on to the neurological conditions, and I'll go into stroke more specifically now. But other things like multiple sclerosis, Parkinson's, spina bifida all have can have an impact on continence. Obesity, so actually carrying that additional weight can have an influence. A spinal injury and an actual, disturbance in the pathways that are there to manage continence. And urinary tract infections can be a sort of short-term source of incontinence, but some people can have long-term infections. So being aware of all of those factors that can already be in existence, unrelated, but might make any incontinence that occurs after a stroke worse, or might have already been sort of there anyway, and it's only actually experiencing the stroke and identifying that incontinence is an issue that it becomes unearthed and an opportunity to do something about it. So I just wanted to, and this isn't going to be too heavy, but I just wanted to go into why stroke can affect continence. So I'm not going too heavy into the kind of physiology, but as I was hinting at before, there are a few components or bits of us that need to all work in combination to enable us to retain continence. So there is the messages to and from the bladder and bowel that need to be received. They need to be transmitted to the brain, and then the triggers to do the appropriate thing needs to come back. So that can all be interrupted in terms of stroke. And there are other factors that will go into what might lead to incontinence in and around stroke or during the recovery time. So clearly a reduced level of consciousness it influences your ability to use the bathroom or what's going on. So that's in the very acute phase. In the time that follows a stroke, reduced mobility, it may be that you're processing the signals, that person's processing the signals and getting all the right triggers, but can't actually get to the toilet in time, which can then lead to incontinence episodes. Communication difficulties in terms of being able to actually just communicate the need for the toilet and the bathroom, and sometimes the urgent need for that, and that can be slow in terms of communication, and then the incontinence episode has already occurred. Reduced cognition, so the interpretation of those signals and the processing of what they mean can be altered in the time after a stroke. Medications can make symptoms worse and need to be considered when we're looking at kind of reversible factors that we might be able to improve a continence status of an individual when we look at the whole picture. And then dietary influences, so the amount of fluid that's being consumed, the type of fluid that's being consumed. I'll come on to it a bit more in the kind of strategies but shortly. But things like caffeine can be a real trigger for sort of an overactive bladder, when your bladder is getting impulses and feels like it needs to empty when it hasn't even filled. That can be a factor. Thinking about things like the fluid in your diet, so the amount of fluid going in. If there's, we need to all drink enough, but often can sometimes drink too much, and that's obviously then in the circulating system and it has to go somewhere. And thinking about the foods that we eat, so there can be real triggers in terms of the consistency of your poo, and that can then mean it's harder to actually stay continent if you've got a liquid sort of stool instead of a solid stool. So thinking about all the things that are going into your body and that they need to come out, and how we might be able to influence them. So then in terms of stroke specifically and what we know from the data, I'm not going to make it too research heavy, but ultimately just wanted to highlight that this is a known and significant problem following stroke, and at different time points as in the acute phase and then as people recover. So from a review done in 2005, we know that 1 in 4 are experiencing urinary incontinence, so bladder leakage on discharge from hospital. And 15% are still experiencing that at 1 year. So it doesn't necessarily go away. And it's about that phase of sort of, like I was trying to say at the start, about not just accepting it, but kind of thinking, okay, well, can something be done to make this better? At 1 year, if there's still, 15% of people experiencing incontinence, that's an opportunity to look at improvement. in a study, a more recent study in 2009, and it was a larger study, so that means it's more powerful. And we can tell more from the findings that 1 in 3 were still experiencing bladder or bowel dysfunction when they were starting their rehabilitation. And then another study looking specifically at bowel habits, or what's occurring in terms of the bowels related to stroke. We know that 1 in 4 had constipation and 15% fecal incontinence. So again, not an insignificant amount of people. What I will say is there's less research in terms of the bowel side of things related to stroke and continence and continence in the main. But it's good to see this study that's really highlighting that this is a reasonable number of people who are experiencing these symptoms, and therefore not to be ignored is the key thing. So the take home from this slide really is that we're looking at about 1 in 4 people who've experienced a stroke experiencing incontinence, and that opportunity to do something about it. And the why is, at a very personal level, started on the first slide saying continence is, central to our dignity. So we'd all want to retain our bladder and bowel continence if we could, if we had a choice in it, clearly. But the actual consequences of experiencing incontinence can be quite far-reaching, and the impact of that really needs to be acknowledged, about how it can make a person feel, so that negative impact on mood, self-image, confidence. People are at various stages in the recovery of their stroke, and if they're doing really well and starting to get out and about, and then it's actually incontinence that becomes a limiting factor and makes them feel really not their confidence, and that's something that has to be addressed, and we've done so well to sort of recover. And it can inhibit the rehab phase, so it can actually get in the way when you're thinking about what you're able to do in terms of really pushing that rehab. And then can have influence on requirements for ongoing care. We know it's often the tipping point that means family and friends are no longer able to cope when there's extensive incontinence, or it's just getting a lot to deal with when people are doing their best but they're not formal carers. It can lead to isolation and embarrassment, so staying at home, avoiding social activities, family activities, physical activities, obviously depending on where people are in terms of their recovery, and that kind of isolation in terms of not speaking to people about it. This is such an area that is shrouded in secrecy. My whole mantra really is about encouraging conversations around bladder and bowel health, because it really is the first step to unlocking what can be done around it. But we've still got such a taboo around these things. But if anybody's experiencing these symptoms, I would urge you to have those conversations and really pursue what can be done. And as I mentioned, that impact on informal carers, it really is can be quite difficult to manage, and also crosses mixes the lines or crosses the lines in terms of relationships when you're really looking at conducting intimate care for a family member. And also there are very practical considerations such as skin breakdown, pressure ulceration, wound management that then can have consequences on that person's health. So the impacts are far and wide, beyond just the incident of actually having an accident, and start to creep into everyday life. So really is an important area that's so often overlooked in general, but in relation to the kind of bigger picture of what else is going on from a stroke management rehab point of view, it really should be sort of quite a high priority in that profile. So I wanted to lead on to more of a what can we do about it, and an action plan, as it were, to just sort of take away in terms of thinking around this topic. And this was an acronym I came up with back a while, about disarming leakage. And it's just really so something sticks in your head, but I hope it will help to plod through the next few slides. It just provides some sort of signposting and action points for if you encounter somebody who's experiencing incontinence related to stroke, if you're somebody who's experiencing incontinence related to stroke, and really kind of challenge the thinking around it and what can be done. So the first part of disarm is don't ignore it. I hope that's come through in the first, what I've covered to this point in the slides. That really is my sort of mantra through all of what I do, is that we shouldn't ignore it. There's a real temptation to normalise incontinence in terms of, what we expect. As I say, so, what happens when you have a baby, that kind of thing often gets talked about, and similar perceptions might be made around stroke. It can happen and it's just what happens. Let's not ignore it. There may be things that can be done to improve these symptoms, and we should always be pursuing that improvement in symptoms. Often also people think they're the only one. Absolutely not. I hope the data has proven that there are many people aside from people who've had a stroke who experience incontinence. And that we don't often want to talk about it, both healthcare professionals and individuals who experience the symptoms. And if we do sort of gather up that courage to talk about it, we often don't know who to talk about it. But I'll come on to that shortly. But the important thing is to talk about it, to not ignore it, and to think what can I do, what can I pursue, or what could I do to help this person, rather than just accepting it. So there are a number of self-help strategies that can be employed, in general related to incontinence. And I'm not saying everything can be cured, and obviously the reason for the stroke may mean that some of these things just won't work. So this need to be sort of realistic about that, but recognizing that some self-help strategies, and it's certainly worth trying because they do no harm. So certainly looking at things like in relation to fluid and diet. So as I alluded to earlier, the amount we drink, we definitely need to drink enough. This can go two ways in terms of the amount, because often for fear of a leakage, people will limit the amount of fluid they drink. And we do need to drink enough in order for our bladder to fill and empty appropriately and retain that cycle. But we also don't need to drink too much. We hear a lot in the sort of media and stuff about how many litres we should drink a day. And actually what we need to be drinking is the right amount for us and the right types of fluids. So another thing that can be tried is cutting out caffeine. So caffeine's in lots of things that we perhaps don't think it is. So the sort of soft drinks and the carbonated drinks, coffee, tea, and it's thinking about trying to limit caffeine and see if that makes a difference, or remove caffeine and see if that makes a difference. But what I would point out is that if it makes no difference and it doesn't seem to be a trigger, then there's no point continuing with that. It's absolutely, if it makes no difference, don't stop enjoying your cup of tea. But if it does have some influence on what's happening, then it's worthwhile knowing that, not to say never have a coffee, but that, if you're going to do something, that coffee might be a trigger. So thinking about that. And similarly with alcohol, both the sort of amount of fluid and the fact that it can stimulate the bladder. And this isn't a comprehensive self-help slide, as it were. So there's lots of things in terms of diet. So thinking about the fibre content, the kind of triggers that might be in that intake, sort of spicy foods, that kind of thing. And also, again, what we hear is that people sort of limit their intake when they know they might have to go and do something the next day, or kind of, might have a hospital appointment. So for fear of that accident, they will not eat. But it's absolutely critical that people, for their own recovery and their own health, do continue to eat and drink appropriately, understanding the linkage that might occur there, and what influence, control you might be able to have over that. In terms of sort of strategies, I've highlighted pelvic floor muscle exercises. This is one bit like a training program of any sort of muscle. This is a structured set of exercises that can be done to strengthen the pelvic floor if it's due to a muscle weakness. And the key thing to recognise is that exercise is often and for life. It doesn't just cure things overnight. So about understanding perceptions around pelvic floor muscle exercises and keeping going with it, and ensuring that it's correct and those kind of things. I will come on to a resource that can help with that. Alongside those kind of strategies are things like bladder retraining, where if people feel their bladder's emptying too quickly, or they're often back and forth to the toilet or keep going to the toilet, the bladder can be retrained to take a little bit more and take a little bit more until it's taken a more than usual capacity for that individual. But again, that could be in conjunction with sort of that help and the resources and the services that I'm going to come on to. I was going to highlight the A of Disarm is to highlight an app that is quite helpful that we developed through BABCON, that is a self-help resource. So the reason I'm the time we've got today, I can't go into all of the things, but this app is definitely worth a download in terms of understanding more about incontinence and the help and advice and strategies that might be able to help, and does have a really good video in there by one of our lovely pelvic health physiotherapists from Southmead Hospital about conducting pelvic floor exercises within that. So it's quite a useful resource. I'll just quickly play the video. Hopefully it plays. Can you hear that?
No, we don't have the volume. We've got the picture, but not the volume. I think there is something around when you're sharing that you've got to do.
Right, okay, no worries. I'll let it play out just because it gives a bit of an idea, but I'll talk it through. It's only my voice on the video anyway. But essentially, it's got lots of sections around understanding what's going on with incontinence, what can help, support for carers and other organisations that are around that can be a source of support within that sphere, and knowing when to seek help from more healthcare organisations, which I'm coming on to. So just to highlight, it's a free resource. Clearly is an app, and apps aren't for everybody. We are looking to get sort of a paper copy of it soon as a little fold out leaflet, but just it is quite a useful resource, both for healthcare professionals and for individuals in terms of understanding more around incontinence and the kind of reasons it can happen. But I will move on. So the R for disarm is about being realistic. So I fully believe that we should challenge incontinence, and that symptoms can often be improved, or if not managed well, and the support you get with that can really help to optimize the situation you're in. It's about being realistic as well. So, for example, not a quick fix. In terms of recovery from stroke, there may be recovery that's still undergoing that you can't, shortcut. It still needs to occur, but that focusing, not accepting incontinence and being realistic about the time frames, but not giving up on it, is really key. So aiming for improvement rather than instant cure, recognizing when improvement has occurred, and that might be incremental and sort of slow growing. There might not be one solution. It might be that, caffeine is some part of it, or, your pelvic floor exercises help a bit of it. So thinking around that and the kind of self-help and things you can do. But it's also okay to stop what isn't helping. So when I mentioned about caffeine, if it's making no difference and you've stopped caffeine, then by all means go back. And recognizing that pads can be a supportive interim step. So we don't say just using pads as a solution. They may very well be needed in the long term if things can't be improved. But if things have been improved and they're still required as a sort of safety mechanism, or they're needed while things are improving, then they absolutely do play a crucial part in that recovery. And there are many and varied and male and female versions out there. So it's worth sort of, really looking into what is available and what might work for you. And then the arm is about understanding that there is medical expertise out there, and there are resources and places you can go to find that help in terms of incontinence. So in terms of Bladder and Bowel UK, and online support and other charities are available. So that's sort of very personal sort of surfing you can do online in your own time. But your GP is a very valid source of healthcare advice, clearly, but in terms of, I think often the perception, and we know from researchers that it's not seen as an important enough issue to speak to a GP about, where it absolutely is. And that should take part, form part of that holistic care, looking at it in relation to stroke recovery too, but also recognizing that incontinence shouldn't just be accepted as a part of that and can be challenged. Then the further steps on are there's the specialist service, the Bladder and Bowel service, who provides specialist assessment, very targeted individualized strategies targeted to the reasons for your incontinence, for example, and monitor that and how that's going to enable those symptoms to be improved as much as possible. And then there's also secondary care, the hospitals, for further investigation if it's required, because there may be other reasons that the incontinence is occurring as well as a consequence of the stroke. So I'm end my slides now. I just wanted to say, take nothing else away. Definitely take action if you're bothered by leakage. I'm not saying everything can be cured, but there's certainly a reason to pursue improvement, recognising the wider reaching implications of incontinence, and the opportunities for improvement that can be undertaken alone, self-help, family, carers, but also in the more sort of healthcare sphere, and just don't ignore it, essentially. Thank you.
Thanks, Nikki. I'm just going to pause the recording.